And moving towards the last talk of this session, I would like to call on the stage Dr. Sumera Batool on the topic of the management of the hormonal shifts in post-menopausal women. And she is the consultant endocrinologist at AKU. And Dr. Sumera, please come on the stage.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. So the topic I'm going to discuss is managing hormonal shift in a post-menopausal woman. So these are the objectives of my presentation. So the first thing is, what is menopause? So a woman is diagnosed as having menopause if she has not menstruated for more than a year, and it is due to cessation of the follicular activity in the ovaries. Most of the women, they enter into the menopause in between the 5th and 6th decade of life. If the menopause occurs before the age of 40, it is abnormal, and it is termed as the premature ovarian failure or primary ovarian insufficiency. There is another common term which commonly used in our clinical practice, that is perimenopause. So perimenopause is the menopausal transition. So it refers to the time when the menstrual irregularities start and the woman began to experience the symptoms of low estrogen. So this is the menopausal transition timeline. If you can see here, we have 4 phases: premenopause, perimenopause, menopause, and then postmenopause. So this perimenopause is the time just before the menopause, where the menstrual irregularities are starting. The woman began to experience hot flushes, night sweats, mood swings, and the estrogen levels began to decline. When the menstruation completely stops, this is the phase called menopause, and at this time there is little or no estrogen in the body. After that phase is postmenopausal time. So if the woman presents after the age of 45 with cessation of menstruation, we can reliably make the diagnosis on clinical grounds that she has entered into the menopause. FSH is not always required to make the diagnosis. But if a young woman presents with amenorrhea, we need to rule out the other causes of menstrual irregularities, and we do the relevant workup in FSH level to make the diagnosis. So menopause is a natural thing which comes in the life of every woman. So why are we talking about it? Because menopause can have a significant impact on the life of a woman. So these are the symptoms which a woman can experience during the time of menopausal transition and after the menopause. So hot flushes and night sweats are very common. Genitourinary symptoms are common, including the urinary incontinence, vaginal dryness, irritation, inflammation of the vagina. There are also metabolic changes going on in the body, resulting in weight gain and dyslipidemia, increased chances of type 2 diabetes, and other psychosexual effects are also very common in such females, which we are going to discuss in the coming slides. So the vasomotor symptoms include hot flushes and night sweats. More than 80% of the women, they experience these symptoms, and they usually start in the late reproductive year and then continue on in the postmenopausal time. Vaginal dryness is common because the epithelium of the urethra and vagina, it is estrogen dependent. So the estrogen levels decline, this epithelium, it gets atrophied, resulting in these symptoms. Cardiovascular risk. So we usually say that women are at low risk of developing cardiovascular disorder because of the protective effect of the estrogen in younger life as compared to the men. But when the menopause starts, this protective effect is lost. Now the women are more prone to developing cardiovascular disorders. And because of the estrogen deficiency, there is an abnormal lipid metabolism, abnormal fat deposition, resulting in insulin resistance and increased risk of developing type 2 diabetes. If we talk about the bone health, again, estrogen is important for the bone health. When the estrogen levels are low, there is an increase in the osteoclastic activity and with a lack of increase in the osteoblastic activity. This results in net bone loss, increased chances of osteoporosis, and increased fragility fractures. Psychosexual effects, these are the symptoms which we tend to pay less attention in our busy clinics, but these are important for the female. They are more prone to develop depression, sleep disturbances, cognitive changes are reported in the observational studies because these women are more prone to develop memory loss and decrease in concentration. Joint pains are very common, and overall, there is a reduced quality of life. So let's discuss a scenario. This is a case of a 55-year-old female. She is known hypertensive and type 2 diabetic. Both of these conditions are well controlled on medication. She has reached menopause at the age of 50, and she has now presented with frequent and severe hot flushes, especially during the night. She has experienced episodes of intense heat, sweating, and flushing. Along with hot flushes, she wakes up soaked in sweat, contributing to poor sleep quality and feeling of exhaustion. She feels increasingly irritable, anxious, and tearful, with fluctuating moods that has affected her relationship with her family members and also affected her daily activities. So these symptoms have worsened over the last year, and she has come to seek treatment for these symptoms. So you see, there are a lot of symptoms which are affecting her routine life and making her life difficult. So what can we do for her? There are multiple treatment options available. We have non-pharmacological treatments, we have non-hormonal treatment options, and then we have the famous hormone replacement therapy or menopause hormone therapy. Mainly we are going to discuss about the hormonal therapy. So there are 4 approved indications for, of hormone therapy which are approved by the FDA. The first one is moderate to severe vasomotor symptoms. Second one is prevention of osteoporosis in a post-menopausal woman. Third is primary ovarian insufficiency. And fourth is moderate to severe vulvovaginal symptoms. So in general, who should we start hormone replacement therapy? A woman less than 60 years of age and less than 10 years past menopause. This is the time period when a woman will get maximum benefit from the hormone therapy, and there will be a low risk of side effects. In hormone therapy, we have estrogen and progesterone. So a woman, if she has a history of hysterectomy, then estrogen alone is enough. But with the intact uterus, estrogen plus progesterone will be required, because estrogen will cause proliferation of the endometrium, and if estrogen is continued, it will cause endometrial hyperplasia, and there will be an increased risk of developing endometrial cancer. So you have to give progesterone along with estrogen to cause the cyclical shedding of the endometrium, so risk of hyperplasia and cancer is reduced. So estrogen is taken daily, and the progesterone is added cyclically in the last 10 to 14 days of the cycle. In our clinical practice, we advise our females to take estrogen daily and add progesterone from 15th to 25th of every month. Other than that, we have continued combined regime, combined estrogen and progesterone combination pills. Different estrogen preparations are available. We have oral estrogen like conjugated equine estrogen, 17-beta-estradiol, transdermal estrogen patches, topical and vaginal preparations. Unfortunately, in Pakistan, we don't have the transdermal estradiol. Oral tablets are available, but sometimes even those are short. Different progesterone preparations are also there, medroxyprogesterone, norethindrone, and all these. So this is a trial which was evaluated in Women Health Initiative. So you can see 2 groups. The first group is a group of women who have received estrogen alone. So this is conjugated equine estrogen. And this is the estrogen plus progesterone group. This dotted line represents less than 10 events per 10,000 women per year. So the event below this line is considered as a rare event. And if it crossed this line, this is considered as significant. So if you see in the estrogen group, there was a risk of DVT and pulmonary embolism, but the risk was very small, like it doesn't cross this dotted line. So the risk was rare. But there was no increased risk of stroke, breast cancer, CVD, or death from any cause. And if you look into the combination group, there was a risk of DVT, and this risk was significant. But other than that, pulmonary embolism, coronary heart disease, stroke, breast cancer, the risk was not very significant. And there was no increased risk of colorectal cancer or death from any cause. So you can see this hormone therapy, this was pretty safe. This trial showed that conventionally we think that hormone therapy will cause a lot of side effects, but this trial has shown that it's pretty safe. But important thing to note is the women who were included in this trial were aged between 50 to 59. Again, as I have mentioned earlier, the most benefit the woman will get if the age is less than 60 and there is less than 10 years of starting the menopause. This is the time when the risk of side effects will be low. For treating the vasomotor symptoms, systemic estrogen is required either in the form of oral tablet or the transdermal patches. Both are equally effective. But the transdermal patches, they have the benefit of bypassing the first half metabolism from the liver, so the risk of side effect will be low. If we talk about the genitourinary symptoms, low-dose vaginal estrogen preparations are very effective with a low risk of side effects. And in fact, because they have little systemic absorption, they will not act on the endometrium and they will not cause endometrial hyperplasia. So progesterone is not required to be used along with vaginal estrogen. Vaginal estrogen preparation do not cause increased risk of breast cancer, cardiovascular disease, thromboembolism, or endometrial cancer hyperplasia. However, it should be used with caution if the woman has undiagnosed vaginal bleeding or the woman is at risk of developing estrogen-dependent neoplasias. For the urinary tract symptoms, hormonal therapy does not improve the urinary stress incontinence or the urinary tract symptoms. The only thing which improves with the use of hormone therapy is risk of UTIs. So FDA has not approved this hormone therapy for urinary health indications. So if we talk about the quality of life, so the woman I have discussed earlier, she was having so much symptom that her quality of life was compromised. So if we improve those symptoms, the quality of life will automatically improve. So systemic hormone therapy can improve menopause-specific quality of life in women experiencing menopausal symptoms. If we talk about the bone health and osteoporosis, again, the age younger than 60 years or within 10 years of menopause onset, systemic hormone therapy is an appropriate therapy to protect against the bone loss. And if a woman develops menopause at an earlier age, then hormone therapy is required till the appropriate age of menopause for the bone health. For metabolic syndrome and diabetes, although hormone therapy is not approved for these indications alone, however, if the woman has metabolic syndrome and diabetes, she can use hormone therapy. This is not contraindicated in the presence of these problems. Hormone therapy has no effect on the subclinical atherosclerosis progression and coronary artery calcification in RCTs, so it doesn't improve the risk of CVD. However, again, if the age is older than 60 years or there is more than 10 to 20 years after the start of menopause, if we use these therapies, then the risk of heart disease, VTE and stroke can be high as compared to the younger population of women. If the woman has a history of breast cancer, then the hormone therapy should not be used. But if the woman is experiencing severe vasomotor symptoms which are not responding to the other therapies, then low-dose therapy can be considered, but in close coordination with her oncologist. For non-thrombophilia patients, hormone therapy is not appropriate because it will increase the risk of thromboembolism. In those cases, other treatment options should be explored. So for how long you should give hormone replacement therapy? The guidelines say the treatment should be individualized and the woman should be assessed annually to check for the appropriate treatment option, whether it should be continued or not. So for the case I have discussed earlier, what should be the treatment option for her? Because she was experiencing so many symptoms, so she should be starting the menopausal hormone therapy, including the cyclical progesterone and estrogen. Because she has intact uterus, so she should be given a combination of estrogen and progesterone. These are the various estrogen preparations available here in Pakistan, although ye bhi kabhi kabhi nahi milti. These are the combination pills. If we talk about non-estrogen preparation, there are certain non-estrogen preparations which are approved by FDA for the treatment of vulvovaginal atrophy in the post-menopausal woman, and these include ospemifene and intravaginal DHEA. Ospemifene is a selective estrogen receptor modulator, and it is approved for the treatment of vaginal dryness and moderate to severe dyspareunia, but it should not be used in a woman with known or suspected breast cancer. So if a woman is not tolerating the hormonal therapy, or if the hormonal therapy is contraindicated, then we have other options like non-hormonal treatments, including SSRIs, gabapentin, oxybutyrate. So depending upon the symptoms, you can choose either of these. And non-pharmacological treatment option, they should always be combined along with the pharmacological treatment options. And these include healthy lifestyle interventions, weight loss, maintaining the weight in the normal BMI range, and cognitive behavioral therapy. So in conclusion, hormone therapy is the most effective treatment for the vasomotor symptoms and genitourinary symptoms. Risk of hormone therapy differs for each woman, so treatment should be individualized. Not all women are at risk of developing the side effects. You need to go for risk stratification and then decide about the treatment option. So the risk will differ depending upon the type, dose, duration, and timing, and whether the progesterone is added with estrogen or not. For women more than 10 or 20 years after the menopause onset, and when the age is more than 60, the risk versus benefit ratio appears less favorable than for the younger woman because of the CVD, stroke, and VTE risk. For genitourinary symptoms, low-dose vaginal estrogen therapy alone can be used, or other FDA-approved therapies like vaginal DHEA or oral ospemifene can also be used. If hormone therapy is contraindicated or not desired, non-hormonal treatment option can also be explored. Thank you.
Thank you so much, Dr. Sumera, for your valuable talk. I would like to ask the question, if you have any question, then you can ask. Any question from the audience, from any of the speaker? If there is no question, then I would like to request our panelists to have a comments on the talk.
Bismillahirrahmanirrahim. I think thank you very much and all the presenters, for Dr. Ali Kramat from UK and Dr. Uzba Malik from here from Pakistan and Dr. Sumera Batool. I think they did a very well presentation and it was very informative, all the topics, and especially the first one is a common problem in diabetic patients, and many patients who come, there's no formal integrated system as in UK in our like primary healthcare or secondary healthcare. So whenever the patient comes to our clinics, whether it's an endocrine clinic or diabetic clinic, and he has got diabetes, if the doctors who are seeing in their primary clinic, whatever clinic is there, they must check their liver function. And if they are abnormal and they are a bit overweight or they feel that they have got the features of metabolic syndrome, that they should give an appropriate advice and recheck it. And if they feel that they are not improving, the things are not improving, they must consult or refer to the gastroenterologist proper advice and all this. Okay? And I would like Mr. Ali Kramat, if you wish to add in anything about that. I think you did very well presentation, very nice presentation. But any other question, if you got, you can talk about this. And you want?
So just a couple of scores which I mentioned, which can be a useful guide for people in the clinic when they're doing the clinics. So I think if you just even Google them and sort of have them on as a resource, the NAFLD fibrosis score and the FIB4 scores, they're not that difficult to calculate in a clinic. So it's just helpful as a guide if you come across somebody with deranged LFTs in your diabetes or endocrine clinic. I think there's a question from the audience.
Just was question from Sumera Batool. I have a very elaborate presentation. Just want to know, there is no mention in his presentation the tibolone. Any role of tibolone in the post-menopausal symptom? Thank you.
एक्चुअली इतना कुछ था इस पे बोलने के लिए, सो इसको मैंने शॉर्ट किया. टिबोलोन आप यूज़ कर सकते हैं if estrogen and progesterone combination is not available, or if there is some contraindication. Tibolone is basically a synthetic steroid which has a property with a weak androgenic and estrogenic and progesteronic property, so you can use for that postmenopausal symptoms as a second line treatment.
The second, I think, any other question regarding the first one? And okay, the second one, I think Dr. Uzma Malik, she did very nice presentation or low TSH and hyperthyroidism in pregnancy. And obviously, if we all remember the physiological changes during pregnancy and what happens in TSH, that many people, they will not get, unnecessary treatment, in these cases. The second thing is my comment on that. It was a very nice presentation, but this autoimmunity in Graves' disease and hyperthyroidism pregnancy gradually reduces, by the end of third trimester. So I think the patient has to be seen every 4 to 6 weeks with repeat FT4 and TSH and FT3 and see what is going on, with the TSH and all that, and adjust the medicines. And they have to gradually reduce it, and sometime 1 or 2 months before we have to stop it also, and at the same time we see the clinical evaluation as the results of thyroid function test. If the patient is stable, it is good for the pregnancy, and to avoid unnecessary medicine at the time of end of pregnancy, if it is not needed. Don't try to keep the TSH between 1 and 2, in those cases. If it is little low, it is better for the pregnancy outcome. So that is my comment on that, it was a very important topic and very good topic. And I think the people who know, people should be referred, the primary physician or the other physician who are not able to handle it, it should be referred so that the pregnancy proceeds normally without complication. So the third talk is Dr. Sumera Batool, I think. It was about menopausal symptoms. I think it is a common problem, and the women Many times they come to our clinic, they are diabetic or whatever is the problem, hypertensive, whatever is the problem, or thyroid. And if this in that age group and they start developing menopause, they will tell you the symptoms in the clinic that they are getting these symptoms, palpitation, hot flushes and all these things. So as a doctor, it is our responsibility that if we wish, we can do the workup also, but you know that if clinically we think that this is the menopausal symptoms, we have to explain that this is our diagnosis, your provisional diagnosis, and these symptoms will gradually go away. It is not very serious if the thyroid function, everything is normal in those cases. So I think that it is to reassure the patient, they feel satisfied, and obviously you can give the option of using the HRT also in these cases. And moreover, the side effects complain, and sometimes the withdrawal bleeding can occur also in these cases. So most of the women, in my experience, they don't actually opt for the HRT, you know. But anyway, in certain situations where you feel that is needed, you will convince and they will give that treatment. That is definitely. Any other question regarding these kind of cases, you can ask Dr. Sumera Batool, you know, if anybody's got any question in the mind.
First of all, thank you very much for your talk that was full of energy. And let's suppose a female who develops menopause at the age of 41 years, and she's not experiencing any symptoms related to menopause like vasomotor symptoms and things like this. Do we need to continue or start HRT till the natural age of menopause? In this individual space, especially when she doesn't fall in the age of premature ovarian insufficiency. She has menopause at the age of 41 years. Thank you.
So if a woman develops menopause in a premature age, like जो normal norms हैं उससे पहले develop हो रहे, you have to give HRT for the bone health. आपको देना है वरना वो osteoporosis के risk पे होगी. It's not about the vasomotor symptom. Premature menopause अगर हो रहा है तो recommendation is to give HRT. 41 is again a premature. It's younger than the normal जो menopausal age है उससे पहले.
Okay, thank you, Dr. Sumera. We are running short of time, so we are moving the conclusion of the session, and there is a...
I think I'll ask my colleagues to give the comments also.
Okay, sir.
No, actually, in the interest of time, we'll keep it very short. Dr. Ali Karamat, it has always been a pleasure to listen to your talk. MASLD, whoever changed the name, did a great job, because when the word metabolic is attached to it, suddenly our interest has increased. So I think everybody here should take one point, that is, you should intervene now. You should talk about lifestyle modification, and it's very easy to calculate the FIB score. Dr. Uzma Malik, you did a great job, and I have almost all of us have seen pregnant patients treated necessarily with the drug which is not trimester specific. So your talk was absolutely wonderful, and Sumera, you did a great job. Menopause very less talked about. Most of the females, they don't even tell you the complaints. So it's now when Dr. Sumera has talked so great about it, I think you should ask the complaints and you should then discuss. Thank you so very much for the very nice presentations, Dr. Mevish.
Thank you very much for insightful presentations. Dr. Ali, it was a wonderful presentation, and I would like to emphasize that liver is not only the victim of metabolic disease, it is the key role player. So as you said that it is very important multidisciplinary approach and liaison with gastroenterologists, hepatologists and endocrinologists, very crucial, and proper referral system, so that it should be an integral part of screening of routine diabetes care. And Dr. Uzma, coming to your presentation, wonderful, managing low TSH in pregnancy. I think addressing the fine balance between thyroid functions in pregnancy and true hyperthyroidism, it's all that is important for better fetal maternal outcomes, and in liaison with gynecologist, close monitoring of FT4 and careful use of antithyroid medication leads to effective and safe treatment throughout the pregnancy. And I would like to emphasize that Dr. Sumera, you did a great job, and your insights I would like to appreciate on post-menopausal hormonal shifts. And you raised very important aspect of mental well-being. Apart from the major vasomotor symptoms and bone health, very important, the cardiovascular risk you told us, but the mental well-being is very important, that is often overlooked. So I think the personalized treatment, weighing benefit to risk ratio is all that we have to do as clinicians. Thank you very much.
Thank you so much, all the chairs, for your comments. And now I would like to conclude the session, and I would like to call the Dr. Umar Raja on the stage for the panel discussion on osteoporosis.